Welcome to this video on cardiac anatomy and physiology. We are going to be reviewing basic anatomy of the heart. We'll look at how the coronary arteries supply blood directly to the heart. We will look at how the heart actually creates the heartbeat, how the innervation moves through the heart to create contractions. And then finally we'll look at how nervous innervation actually gets to the heart itself to start off the control of the heartbeat. So as I mentioned, we're going to start just with basic anatomy. This is what the heart looks like from the outside, not quite like a Valentine. You can see that a large portion of what you see from the front is just the right ventricle. You see a little bit of the left ventricle, and then the tip or the apex of the heart is really the left ventricle. If we could rotate this view, you'd see the back of the heart was pretty much all left ventricle. And then the two small chambers on the top, again, you can see most of the right atrium here, and you can see a little bit of the left atrium there. So this is positioned about in the center of the chest, a little bit to the left, and as you know, the blood pumps through this in a certain order, certain way. So we see here the superior vena cava and the inferior vena cava. So those are the two major veins that are bringing blood back from the head and the upper extremities and from the trunk and the lower extremities into the right atrium. We'll come back to that picture. So when it comes into the right atrium, that is going to then contract and sends blood down into the right ventricle. So that's number 5 here. When the ventricle contracts, it's going to send blood out through the pulmonary artery, and you can see here they're kind of color-coded. So blue means it's deoxygenated blood. So this is the only artery that carries deoxygenated blood. So the reason it's called an artery is because it's going from the heart to another structure in the body. So it's going, of course, to the lungs, goes through the pulmonary circulation, comes back in through the pulmonary vein, and this is going to go to the left atrium. So again, the pulmonary veins, again, you've got veins on the right and left from each lobe. The veins here are the only veins in the body that carry oxygenated blood. So now you can see here the colors turn to red, indicating oxygenation. So that's brought blood. Since it's a vein, it's bringing blood from another body structure into the heart. That's why it's called a vein. But since the structure is the lungs, it's oxygenated that blood. That blood then is pumped down into the left ventricle, number 11 here, and that, of course, when it contracts, gets pumped out through the aorta to the rest of the body. So I said we'd go back. This is a view of the heart sitting within a cadaver. They have taken the lungs out, so you can't see, those are kind of the empty shells where the lungs would have been. Here's the diaphragm forming the division between the abdominal cavity and the thoracic cavity. So as I mentioned, the right atrium is pretty small, sitting up on top of there. Most of what you see here is the right ventricle, a little bit of the left ventricle here. A lot of what you see here, look how big the aorta is, pumping that out to the rest of the body. So of course, to control blood flow through the heart, we have to have valves to prevent backflow, because both the atria, right and the left atria, contract together, and then both the ventricles contract together. So when the right atria and the left atria are both contracting, they're going to concurrently push blood down into the right and left ventricles. And then similarly, when the right and the left ventricles are both contracting, we want that blood to be pushed out, in the case of the right ventricle, to the lungs, and in the case of the left ventricle, out to the rest of the body. So particularly when those ventricles contract, we don't want backflow into the previous structure. So when the right ventricle contracts, when the ventricles contract to prevent backflow from the blood in the right ventricle to the right atrium, we have the tricuspid valve. So tricuspid, 3 cusps or 3 flaps. So that is a one-way valve, just like we've talked about in veins, for example. That's going to prevent blood from flowing back into the right atrium. We also have the mitral valve between the left ventricle and the left atrium, so that's preventing backflow up into the left atrium. Mitral valve has also been called the bicuspid valve. Once the ventricles have contracted, they're pushing blood up into vessels, so we don't want backflow from the pulmonary artery back into the right ventricle, so we have a pulmonary valve, and then we don't want backflow between the aorta back into the left ventricle, and then we would have the aortic valve. So failure of this aortic valve in particular can be one of the causes of heart failure, because if you're pumping, the ventricle is pumping hard, but part of that blood falls back into the left ventricle, it's not going to be a very efficient way to deliver blood flow to the rest of the body. So let's look, coming off the the aorta directly are the coronary arteries. So let's look at those. The reason it's important to understand this is because if we know which artery has been blocked or is damaged, we can tell which part of the heart might be involved as well. And so we just need to know the general anatomy or general vascular delivery from the heart. So basically we have a right and a left coronary artery. Probably doesn't surprise you to know that since the left ventricle in particular is so much larger, we're going to see some divisions of that left coronary artery. So let's look at the right coronary artery first. It's coming down and around, and it's going to supply the right atrium, the right ventricle. We can't kind of see it going around the back, but it's going to deliver blood to part of the left ventricle, the inferior wall in particular, the AV or atrioventricular node, most of the sinoatrial node, and then also the bundle of His. So those last three, AV node, SA node, and bundle of His, you'll see are all very important in conduction of the heartbeat. So those are nervous structures. So the left coronary artery then, we first have the main stem coronary artery, off of which we're going to have things branch off. But not a very exciting name, but it's also called the widowmaker, because since it's supplying blood to such a large portion of the heart, if that left main stem coronary artery is blocked, pretty much have a condition that's not compatible with life. So we can see two major divisions, the left anterior descending branch and then the left circumflex. So anterior descending, pretty much like its name says, it's on the front of the heart and it's descending or going straight down. This is going to supply most of the left ventricle, the septum, which is the wall between the two ventricles, some of the right ventricle, and then the very inferior part of the ventricle. The left circumflex, so circumflex like circumnavigation or going around, you can see this is going around toward the back side of the left ventricle here. That's going to supply, again, the inferior wall of the left ventricle and left atrium, and then the other part of the sinoatrial node. One of the important things to appreciate is that blood can only flow through those coronary arteries when the heart is relaxed. So imagine during systole, when the ventricles are contracting, that's creating a lot of pressure in the heart. So those muscles are contracted. And you know from our talk about pain spasm cycle, if a skeletal muscle is contracted or in a spasm, blood flow can't get into it because it puts too much pressure on the vessels within the muscle. So similarly, if the ventricles are contracting, there's too much pressure on the cells in those ventricles. Blood can't, or oxygen can't diffuse from the coronary arteries into the heart because the muscles are too contracted or tense. So it's only during diastole, which is relaxation of the ventricles, contraction of the atria, that blood can diffuse from the coronary arteries into the heart. So having low pressure during diastole is really important to make sure that we have, and having a slower heartbeat, so we have a longer period between ventricular contractions, is important for the health of the heart. It allows more blood to circulate. And that's really important because the heart needs a constant supply of oxygen or it's not going to be able to support metabolism because the heart doesn't really have any muscle fibers, any cardiac muscle fibers that can function without a constant supply of oxygen. They all require aerobic metabolism. There's a video here you can watch, and it'll illustrate the elements that I just talked about as far as delivery of blood through the coronary arteries and then into the heart itself. So I'm going to just let you watch that on your own. So I want to go on and talk then about how the heartbeat essentially kind of goes through the heart. And the heart, you should remember that really there are only two types of tissue that can depolarize, nerves and muscles. And the heart can kind of self-pace or self-depolarize. And so that's what we're going to talk about, is how the heart actually can have those action potentials go through it as a whole with kind of minimal input. So the SA node, or sinoatrial node, is considered the pacemaker of the heart. So when we talk about being in sinus rhythm, that's what we're talking about. We're talking about a rhythm that originates in the SA node. And this is up by the superior vena cava and the right atrium, so right here. And basically then we have an impulse starting there, and then it depolarizes and sends signals through the atria, and then that causes the atria to contract. So that's diastole. Then that impulse goes to the AV node, or atrioventricular node, and that's right here between the right atrium and the right ventricle. Those impulses then travel along what's called here the bundle of His. Now I know it looks like his, but it's pronounced bundle of His. And bundle just basically means it's a bundle of axons. And apparently Mr. or Dr. Hiss was the first one to discover these. So this is the bundle of His. And so again, the action potential is traveling along here. When it gets to the point between the ventricles, then it splits. One branches off to the left, the other one branches off to the right. So this is called the left bundle branch. And then this is the right bundle branch. So we have here this main bundle, the bundle of His, and then we have two little bundles branching to the left and the right. And then once they've gone through that, then they go through finally to the Purkinje fibers. And these are the small little fibers that go right into the ventricles. And so it's once the impulse gets to the Purkinje fibers, that's going right into the ventricular fibers, and so that's when the ventricles to contract. So that's going to be systole. So again, we've got a depolarization here at the SA node that spreads through the atria. Here's the little branch over to the left atria. They're going to contract together. Then it takes a little bit longer for the impulse to travel all the way down through to the Purkinje fibers. So we have a little bit of a pause that allows the ventricles to relax and fill with blood from the contraction of the atria, and then the ventricles contract. So there's your lub-dub of the heartbeat. This is just another illustration, a little bit more anatomically accurate, but again, here's the SA node, and you can read through all this text, but basically impulses travel through as they complete traveling through the atria are going to contract or depolarize. Then you're going to get to the AV node. You have your action potential occurring through the bundle of His, then to the left and the right bundle branches, finally into the Purkinje fibers. Then that's what's going to carry the contraction to the muscular walls of the ventricles. They'll contract for systole. Again, a little video here for you to look at and just to review what we just talked about in a little bit more dynamic way. The last thing I want to cover here is actually then what stimulates the SA node to start with. How do we even get a heartbeat started? So here's just an action potential, and this should look fairly familiar to you. And basically, the heart is under two types of control. One is just regular resting control, which is parasympathetic control, and the other is under sympathetic control. So if we look back here, one of the things that's really important to understand is that we have some cardiac cells that can just depolarize without any input at all. And so here it shows our resting potential, somewhere between about negative 60 millivolts, and the threshold is about negative 40, so it's very close. And so we have, again, some cardiac cells that can essentially depolarize and have an action potential and a contraction without the need for any impulse, any input at all, which is kind of a weird thing. It's not something we're used to thinking about. So basically, those sympathetic and parasympathetic inputs will either increase or decrease this depolarization, but they really don't change the fact that the heart can just keep beating. So if the heart beat on its own without any sympathetic or parasympathetic stimulation, our heart rate would be about 100 to 120 beats a minute. Well, clearly at rest, that's much faster than normal. So at rest, we are under what's called parasympathetic control. And you might remember from way back to patient interventions, we talked about, when we just talked about taking heart rate and just measuring pulse, that we know that the hypothalamus and the medulla have there are areas within those segments of the central nervous system that get input from other areas in the body and help us control the activity of the heart. So again, the parasympathetic center is what controls it at rest. So here's our vagus nerve, that's our cranial nerve 10, and that's the parasympathetic control of the heart. So once an action potential travels down the parasympathetic nerve, it's going to tell that SA node and the AV node, it's going to tell them to slow down and not contract so hard. So right now you're all sitting there just kind of relaxed listening to this video, and you are basically under parasympathetic control. Your medulla and your hypothalamus are receiving messages from the rest of your body that tell it that you don't have high oxygen needs right now, hopefully high enough to stay awake. But you don't have high oxygen needs, you're not running around, you're not running away from the saber-toothed tiger, you're not exercising. So you don't have a high need for oxygenation. You're just kind of in resting mode. The parasympathetic control takes care of that, and so it will slow down the inherent contraction at the SA node. And, normal resting rate, as we know, is between 60 and 85 beats a minute. Hopefully your resting heart rate's probably closer to 65 to 70, somewhere in there. Now, by contrast, if we start to exercise, we get frightened, we get stressed, that is going to stimulate our sympathetic nervous system, and that's going to also send information to the medulla and the hypothalamus, and that's going to tell those sympathetic nerves to go out and tell the SA and the AV nodes to speed up. And this is where we get an increase in not just the rate, but the force of contraction of the heart muscle. So what actually can change in addition to our activity? Well, we know a lot of things that affect heart rate. We have baroreceptors in the aorta and in the carotid sinus areas, and they detect changes in blood pressure. So if our blood pressure is going up, the body doesn't want to get past the homeostatic normal, so it's going to tell the heart rate then to decrease. A lower heart rate will try to bring back our blood pressure down. If our blood pressure drops, a way that the body can react to get it back up to a normal level is to increase the heart rate. Of course, we also have chemical receptors that reside in those same areas, and so they're sensitive to changes in oxygen levels, carbon dioxide, other chemicals like lactic acid. So it can tell those changes in those values can also tell the heart rate to either increase or decrease. Body temperature alone can cause the heart rate to increase. We know certainly stress hormones can cause the heart rate to increase and increase the contractile force. And then finally, I'm sure you're all familiar with the fact that electrolyte changes can cause changes in heart rate. So when we talk about somebody having low electrolytes, for example, like potassium, for example, that can cause the heart to actually go into an arrhythmia. It can really disrupt regulation. Often we see low calcium as well, and that would decrease the activity of the heart. So we have a lot of things that can impact on the heart, and what I'd like you to understand out of this are the different elements of the heart that contribute to how a contraction moves through it. I want you to understand the different ways that you can have either sympathetic or parasympathetic stimulation and how that would affect either increase or decrease the heart rate and force of contractility. And then, of course, going back to what we covered at the beginning, just the normal way that blood flow moves through the heart and the different chambers and elements of the heart. So that's it. Hope you enjoyed this, and we'll talk soon.